Good, thank you.
But we are okay. We are fine. So,
Okay, so just give me 5 minutes and I'll start the session. Just like 2 to 5 minutes, okay?
sure, sure.
Hello? Hello?
Hello, yes,
Okay.
I can hear you.
Yeah,
I
hi.
can hear you.
Yes, hi.
Yeah. So for yesterday, we covered all of the liver pathologies except hepatitis. Okay. So first, we can actually do pharma, and then I will just give you a quick overview for hepatitis and what you should know for step exams at least. Okay. So we start with pharmacology first, and let me share my screen. Okay, so first, you have to keep in mind, like we have few class of drugs that work for your peptic ulcer disease, you can say, okay, and other work for your like other are your anti-diarrheal, and some are used for your constipation. Like pharmacology for like GI is quite easy. It's not that difficult, and you always get like one or two question, not more than that, and it's mostly related to
Sorry,
PPIs.
that's
Yeah, sorry.
would you please
Would you
share your
please share
screen
your
because we
screen
can't
because
see?
we can't see? Yeah. So I'm saying like it's mostly related to the PPI stuff. They like to ask the adverse event and mechanism of action, especially mechanism of action. Like you must all know, like it's quite easy. So I will just give you one brief overview. So first you have to think that this is your parietal cell, okay? And in parietal cell you have this hydrogen and potassium pump, okay? You have hydrogen and potassium pump. Hydrogen like pumps out, so because hydrogen combines with chloride, so HCl thing, and this is your gut lumen. You have to think of it in this way, and this is your cell, and you pick up your potassium, okay? There are a lot of, you can say, hormones or neuroendocrine supply for the production of this hormone, okay? First you have to remember is acetylcholine itself, okay? Acetylcholine itself, it if it works on your muscarinic receptors, it can induce your HCl production or your acid production, okay, by G stimulatory proteins. This you have to remember. These details can be asked, so that's why it's important. So G stimulatory proteins, HCl production by your acetylcholine. Where does this acetylcholine come from? It comes from your vagus nerve, okay, from your vagus nerve. And then the same acetylcholine can work on your other gastric releasing, you can say, cells, okay? So you like this acetylcholine from your vagus nerve can actually activate your gastrin releasing protein, and this will go on G cells. On your G cells, it will act on gastrin, and it will lead to gastric acid production. Okay, so like why is it so complex? It's not like this. Like most of the time, you can think of it in this way that your acetylcholine is contractile for your GI gut motility. Okay, so when you have the food, it wants to digest it, and automatically when you move or when you have the gut motility, you want to make more and more acid to digest the food. That's why one way to activate this pump is by acetylcholine itself. Another way is that acetylcholine from your vagus nerve will go and act on G cells. And I don't know, but if you guys know this thing, it's very high yield for at least step one. This is related to the histology, you can say. So if you guys do not know, I would tell you like if I say this is your gut lumen, okay, and this one wall is composed of four layers, okay. You have mucosa, you have submucosa, and then you have muscularis externa, and then you have serosa adventitia depending upon intraperitoneal and extraperitoneal thing. Okay. So, anyways, this mucosa has three more layers. Okay, it is like your lamina propria, and your there's muscularis mucosae. Okay, and there is like epithelial layer. Okay, for histology of your GI tract, this is very very extremely high yield that you need to remember that this epithelial layer of your mucosa. Okay, it it has this pits. It is arranged in the form of pits. Okay, like this is your gastric wall, it's arranged in the form of pits. Okay, the first cells that you see here are your mucous neck cells. These are your mucous neck cells. This you have to keep in mind. Okay, and then comes your parietal cells. Okay, then come your chief cells, and then you have enterochromaffin cells. Okay, then you have enterochromaffin cells. Okay, so what happened is that why knowing this histology is important. I would tell you, like, you will see always a question in which they will ask you what cell it is. They will give you histology and just ask you what cell it is. Now you will be like thinking, how do I know what cell it is? Because it will be zoomed out picture, you cannot understand or comprehend that thing. Go stepwise. Whatever cell lies here in the first outer layer, it's always going to be a mucous neck cell, even if it appears purple, pink, whatsoever. Okay, that is going to be a mucous neck cell. Okay, whatever appears after the mucous neck cell is for sure parietal cell. So, parietal cell. Whatever comes after parietal cell is your chief cell, and whatever comes after chief cell is your enterochromaffin cell. This sequence you have to remember. This is very very important. Okay, and your G cells, they are actually very close to this enterochromaffin cells. So that's why I'm just telling you this thing, because we were discussing about G cells. So like these G cells are sitting very close to this enterochromaffin cells, and they actually secrete your gastrin, and from your gastrin you activate your receptor, that is CCKB receptor, and that works and produces your acid by activating this pump. In nutshell, all these acid suppression drugs, they work on this hydrogen potassium pump. Okay, I'll just repeat it again one more time so that you guys understand. But all the acid suppressive drugs act on this hydrogen potassium pump. Okay, first we have talked about acetylcholine, and acetylcholine normally leads to production of this acid by G stimulatory protein. Okay, if we give anticholinergic, we can suppress this acid production. I hope it's very very clear. The second is, normally your acetylcholine will activate your G cells by releasing this GRP. This G cells will produce gastrin, and this gastrin will act on parietal cell by CCKB receptor. For some reason, you have to keep this in mind. CCKB receptor is very important. Like this is the receptor where gastrin acts on. Sometimes can be tested. I have seen this, so you can just keep in mind about this receptor that gastrin acts through this. Normally, acetylcholine GRP released. GRP stimulates your G cells. G cells secrete your gastrin. Gastrin goes and activates or sits on this receptor, CCKB receptor, on your parietal cell, and this leads to activation of this whole pump thing. Okay, this is the normal thing. And if you again give anticholinergic, no anticholinergic activity, no GRP, no G cell activation, no gastrin production, no activation of your CCKB, no hydrogen acid production. Okay, this is one way you can activate your hydrogen potassium pump, which is your acetylcholine. Okay, the other is your histamine. Okay, histamine. Generally, you will see if, as I have just told you, like anticholinergics can be used to decrease your acid, like to decrease your acid secretions. Okay, but normally we do not recommend using atropine. Suppose it's anticholinergic, but we do not give it because anticholinergic, it has a lot of muscarinic receptors inside your body, on your mouth, in your sweat glands, and stuff like this. So it can lead to a lot of, you can say, anticholinergic effects like bradycardia and stuff like this, so which is very harmful to you. So we do not recommend that. To suppress acid, your first line drug should be atropine. That's the reason we do not recommend it. We do not use it clinically, but for theory purposes or for your understanding purposes, like atropine can actually suppress your acid production. Okay, another drug that we actually use as a second line thing is your histamine. Okay, your histamine, they again lie very close to your enterochromaffin cells, and you're actually like this enterochromaffin cells that are lying here at the base of your crypts, they produce your histamine. And when they produce this histamine acts on the receptor which is known as hydrogen, like a H2 receptor. We have two types of histamine receptor. One are H1 and one are H2. H1 are in your CNS and other stuff of your body. H2 is only limited to your gut. Okay, this you have to remember. That's why these drugs are very specific. Otherwise, histamine also have very adverse effect. Okay, antihistamines do carry their own adverse effect. So you produce your histamine from your enterochromatin cells. They can act on this H2 receptor, and this H2 receptor again will activate your GI. uh, GI. Okay, GI. Like sorry, not GS. This is GS and this is GQ. Sorry about that. But yeah, anyways. So these receptors is also important. GS, GQ thing. I don't know, but maybe someday we cover pharmacology or biochem, then we can discuss about these things. But for now, and to be precise, you can just remember histamine is with GS and acetylcholine is with GQ. Okay, and when these receptors like histamine comes and activate your histamine receptor like H2 receptor, it activates GS, and GS leads to activation of this hydrogen potassium pump. So if you give H2 blockers, you can actually inhibit this whole thing. Okay, the two other, you can say, drugs that are there, but we do not use them as a first line. This is just for theory purposes. You have somatostatin and prostaglandins. Okay, somatostatin is produced by your body. Sometimes you can give it in the form of octreotide. But how does it act? Both of these, somatostatin and prostaglandins, they actually inhibit this pump. Normally, they inhibit this pump. So these are normally inhibitors. Like acetylcholine and histamine, both are normally stimulators. But somatostatin and prostaglandins are normally inhibitors. Okay, so because they are inhibitors, they work by your GI. Uh, this GI, GQ, GS, these are your intracellular proteins that can show up at least for step one. It's like this, can't help it. But anyway, so if you have a lot of prostaglandin production, if you have a lot of somatostatin inside or surrounding your parietal cell, you can actually normally inhibit your this whole ATPase, like sorry, I mean hydrogen potassium pump activity. You can shut it down. Okay, now the most important drug is your PPIs. How do they work? So for PPIs, I want you to consider it in this way, that this is your parietal cell. Okay, and because like you have some yeah, so this is your parietal cell, and this is your hydrogen and potassium pump. Okay, now PPIs, what they do is they you can say they combine with this pump itself. And what this does is it helps PPIs to engulf this whole pump and form invaginations. This is more detailed thing. If you cannot remember, you can just hello. Yeah, so I'm saying if you cannot remember this thing, it's just for your understanding purposes, but there is a reason why I'm telling you. I'll tell you this. So first thing, PPIs inhabit directly this pump. PPIs directly inhabit this ATPase pump. Okay, and what they do is this PPI will combine with this hydrogen potassium pump. Okay, and form an invagination in the wall. So this wall swallows up this pump. Okay, and when this pump is swallowed, and there is no one pump in your body, you have multiple pumps on one cell. Okay, so PPIs, they will go and combine with all the pumps and lead to the invagination of these pumps. Okay, it means the cell has swallowed these ATPase pump. They are no more functional, right? Because normally they should open inside the lumen, but now they are, you can say, surround or engulfed inside the cell. Okay, so what that it leads to is inhibition of this hydrogen potassium pump. Okay, and that's why it leads to irreversible inhibition. This thing is very very higher. There are a lot of questions when they ask you reversible inhibition of your acid secretion is by histamine, like a H2 blocker. Okay, and your irreversible blockage of your this HCl is by your PPIs. Okay, just the overview, and I hope it's very clear to you. And now I will just tell you some, you can say, adverse effect, or you can say some other things, some relevant things that you should need to know. For H2, you need to remember whatever drug that ends with DINE, so cimetidine, famotidine, whatsoever. Okay, they all block your H2 receptors, and you all know the uses of these all drugs, so I'm not going into that detail. This can be, cimetidine actually can lead to your gynecomastia. You have to remember this in males. Cimetidine actually elevates your prolactin levels, so that's why in males you can see gynecomastia. This is something that they want you to know. Okay, it can lead to gonadal atrophy and things like this. So you have to keep this thing. It's very specific for cimetidine. For famotidine or others, it's not so specific. For cimetidine, it's like this. Okay, and I would also tell you that it's a cytochrome P450 inhibitor. This you have to keep in mind also. Like it can sometimes show up, and yeah, these are the only two adverse effects that they want you to know. Okay, at least like these are very high. For PPIs, what adverse effect you should keep in mind is first is your that thing. Um, it can lead to C. diff infection. So C. difficile infection, if you know, it's like when you use a lot of antibiotics, you can develop it. Like normally, we know when someone is using antibiotics, they can actually develop the C. difficile infection. But how do the PPI increase the risk of this infection? What they do is they lead to acid suppression, and if you suppress your acid, it means your normal gut flora that was suppressed due to acidic secretion now can grow up. So that's why it leads to increased risk of your C. diff infection. Okay, this is one thing that you should keep in mind. And other very obvious and very tested, very high yield thing is that if you block your production of your HCl, you know that along with HCl or acid secretion, you have your intrinsic factor that is also co-secreted. Okay, and if for some reason you cannot secrete this intrinsic factor, it can lead to no B12 vitamin B12 absorption. If no vitamin B12 is absorbed, it means you can develop B12 deficiency, which include your megaloblastic anemia. You can develop actually that thing, subacute combined degeneration syndrome. All these things you can develop those disorders. Okay, this is another thing that you should keep in mind. And this PPIs inhibits your reabsorption of your minerals like magnesium and calcium. That's why it can also lead to osteoporosis. Okay, I wouldn't say osteoporosis, it's like very obvious, but yeah, it can lead to increased risk of fracture. At least you can think of it in this way. Okay, and there was another thing that PPS can lead to is your AIN, acute interstitial nephritis. Okay, not ATN. ATN is very different from AIN. This will be another topic, so I'm not going into details. But acute interstitial nephritis is just like inflammation of your parenchyma, your renal parenchyma. Okay, and these all adverse effect, all like for this PPI, all adverse effect are important. C. diff, osteoporosis picture, vitamin B12 deficiency, and your interstitial AIN, acute interstitial nephritis. This all is very very important, especially this B12 part. Like it's very very high yield. Okay, so I hope this is very clear. And
Sorry,
yeah,
sorry.
yeah,
You
yeah.
asked for
Sorry,
porosis.
I cannot hear you. Can you repeat your
You
question?
mentioned that it will lead to osteoporosis.
Yeah, yeah.
Okay, okay. I was just making sure.
Yeah, because why, when you try to remember things, try to like think of them logically first. If you cannot find any answer, then you can just remember it, because why make your life difficult? But as I told you, it leads to decreased mineral absorption like calcium and magnesium. That's why you have increased, like you have like osteopenia, osteoporosis, or fracture picture can be seen with PPIs. Like this is the thing. I remember at my time in our first aid, they used to write osteoporosis. Recently, they have changed it to the increased fracture risk. They do not use the word osteoporosis as such. But anyways, it's the like it increases the risk. So this you have to remember, okay? And I hope these PPIs and the histamine are very very clear to you, very clear. And we can now discuss about other drugs that are your antacids. Okay, for your antacids, I want you to remember there are like two very high yield, aluminum hydroxide and magnesium hydroxide. They are very short lived and they are very quick. You can see quicker relief to the acidity and stuff like this, but they are very short lived. Okay, what they do is they can be used for your to suppress your acid secretion, or to, you can say, to decrease your heartburn, stuff like this. But one adverse effect with aluminum hydroxide is that it leads to constipation. Okay, so A is with C, you have to remember this, and for magnesium it's your diarrhea. Okay, so MD. So MD we know like AC, and I hope you understand like a air conditioner or something. So AC and MD, these are their most common adverse effect that you have to remember. That's why now there is a one form of antacid which comes in combination of aluminum hydroxide and magnesium hydroxide to decrease these excessive adverse effect of diarrhea and constipation. Okay, this you have to keep in mind. I don't know why, but sometimes they do ask. Firstly, antacids are not that much tested. On steps, it's not very relevant, but if it shows, you can remember this. You can remember another thing that because they are, you can say, because they are your minerals like aluminum and magnesium, they can all lead to decreased mineral absorption. Like they can induce hypokalemia. This you can remember. This can be asked. And I remember for aluminum hydroxide you see proximal muscle weakness as well. These are few important points that you can keep in mind. Okay, other than that it's not tested as such. Like I haven't seen that they give you test you a lot on these adverse effect mechanism of action of antacids, not as such. Okay, not as such. Now another point we were talking about prostaglandins. Okay, we are done with H2, we are done with PPIs. I told you we have that thing, the other two inhibitors like somatostatin, and I told you the prostaglandin. Okay, they normally all inhibit your acid secretion. Okay, they inhibit your acid secretion. So in your if you give prostaglandin analog, it means it will decrease your acid secretion, right? Because normally prostaglandins actually decrease the acid secretion. So if you give an analog, it will also lead to decreased acid production. Okay, so what it does is like what kind of prostaglandin you should keep in mind, it's your misoprostol. Okay, and this same misoprostol can actually activate your uterine activity. So that's why this misoprostol is contraindicated in someone who is pregnant. Okay, this is very, you can say, a very concerned adverse effect that you should keep in mind, and it makes sense because your uterus has receptors for prostaglandin. So your prostaglandin can actually induce uterine contractility, and if for some reason the pregnant patient can take this misoprostol, it can lead to abortion. Okay, this misoprostol and methotrexate are both used for your ectopic pregnancy too. Okay, because of these same thing. Methotrexate is different, like it's not a prostaglandin analog, but like we came to the abortion topic, so it just came in my mind. Anyways, don't mix these two drugs. Okay, methotrexate is very different, misoprostol is very different. Both can be used for ectopic pregnancy, but because it's used for ectopic pregnancy, it can never be used for someone who is having normal pregnancy because it's a prostaglandin analog. It can lead to your uterine contraction and can induce the labor. Okay, this you have to remember. And your acids, like your ulcer, it is either formed by your H. pylori. For H. pylori you have quadruple therapy or triple therapy. You must know of that, like you use two antibiotics and one you use your one mucoprotectant like bismuth and sucralfate, stuff like this. Okay, so this misoprostol can actually help you with acid induced ulcer. This is the use of this. Okay, acid induced ulcer, because acid is prostaglandin inhibitor, and if you give the analog, you can suppress this thing. Okay, so it's just a thing that you can remember. All right, I hope it's very clear, and you guys are not confused. And what else I should tell you? Octreotide, you all guys know. Somatostatin analog, again, it can lead to inhibition of your acid production. Same thing, same purpose, same usage. For octreotide, you can actually remember, apart from ulcer, it is used for all of your neuroendocrine tumors like VIPoma, insulinoma, carcinoid syndrome, and you can say esophageal varices. Like this drug octreotide is also important when it comes to your neuroendocrine excessiveness. Okay, or even your Zolliger syndrome. Like for all this stuff, you can supplement or use it. Okay, and okay, so now we have the drugs for, you can say, your diarrhea. Okay, so for diarrhea, I want you to remember that you can use opioids. because you have to remember this, opioids normally lead to constipation. Opioids normally, when they act on receptors, they lead to decreased gut motility. Okay, decreased gut motility. They lead to decreased gut motility. This you have to keep in mind, that opioids normally lead to decreased gut motility, and that's why we can use opioids for diarrhea. Now you may think like, why would I use opioid for a diarrhea? Because it can be abused, right? But the you can say the receptors in your gut for opioid, they are very specific to gut. They are not in CNS as such, and that's why the drugs that target this gut opioid receptors, they have very low, you can say, effect on your CNS, and that's why they are not abused. They are not addictive, and they can be actually used. So drugs like loperamide you must keep in mind. Okay, there is always a question in your mind, like loperamide, how does it act, why doesn't it go and act centrally? Because the receptors are not there, and that's why it's not a substance of abuse, and you can actually use it for diarrhea. Okay, what is the adverse effect? This makes sense because I told you it decreases your gut motility, so it can actually induce your constipation. How can this be tested on your examination? What they will do is they will give you opioid abuse disorder, opioid dependence, someone who is on opioids for some reason they are admitted, and you see someone who hasn't passed stool for last 3 4 days, they will just ask you why is he having you can say constipation. You know this because of the opioid induced constipation. Things like this, like very obvious. Or they can give you opioid toxicity, in which they give you pinpoint pupils and stuff like this, and then just supplement it with the constipation, so you know like what the patient is going through. This is the main idea here. The very high yield or key point here is that it has low addictive potential. That's the main thing. And opioid leads to constipation. That's why it's used in diarrhea. Okay. This is the thing that you should keep in mind. And for diarrhea, I remember opioid is the one that you need to know. For constipation, we have list of drugs. We will actually talk about it. And what else I should tell you? Yeah, for ulcerative colitis, you can remember you have 5 amino salicylic, 5 amino salicylic acid. Okay, this is used for your IBD. This drug is used for your IBD disorders. Okay, and it's, you can say, how does it help? Mechanism of action and these things I haven't seen that they ask you, but this sulfasalazine is the name of the drug. Okay, this sulfasalazine, they can just ask you what it is. It's 5 amino salicylic, and this is anti-inflammatory. Okay, and it has, I remember, it has also a component of antibacterial activity. Okay, like this sulfasalazine is a mixture of, you can say, anti-inflammatory drug and antibacterial drug, so it helps you with the IBD. That's the only thing that you can remember. What other adverse effect that you should remember about the sulfasalazine is that it can lead to uh, that thing, oligospermia. Okay, but that is reversible, of course. If you stop using the drug, your oligospermia or the infertility, like a patient will come with a complaint of infertility, and if they are on sulfasalazine, if you stop the drug, their fertility comes back. Okay, this is the thing that you should remember for IBD. And what else I should tell you? And for anti-constipation drugs, I will go in detail because they are more detailed. Let me remember what other drugs we have. We have antiemetics. Okay, antiemetics. This you should also know. For antiemetics, you need to know, like, you have a chemo trigger receptor zone. Okay, chemo trigger receptor zone, which is known as CTZ zone. This is in your area postrema in your brain. Okay, and this area basically does not have a blood brain barrier, and because it does not have a blood brain barrier, it can sense any of your toxic metabolite that is circulating in your blood vessel. Okay, and that's why it can actually lead to vomiting even if you do not want to vomit, but because this area sensed this toxin, it will lead to vomit. Okay, how does it lead to vomit? Is by serotonin is released, and it leads to gut, you can say, peristalsis, and you vomit. Okay, so that's why for treatment what will you will do is you will give serotonin antagonist. Okay, like ondansetron, stuff like this. they ask you the mechanism of action of this, or they can just give you, someone is vomiting a lot of times, like what drug will you give, stuff like this. Okay, they like to ask this thing. um what should you remember for this is that it can lead to actually serotonin syndrome. This will be a psychiatry topic, I'll not go into detail, but for serotonin syndrome you can just remember two serotonin drugs, if they are given together, they can lead to increased activity of serotonin. Okay, because one is inhibitor and one is increasing the levels of that serotonin. So it can lead to serotonin syndrome. This you have to keep in mind. And I have told you about CTZ, and yeah, this is the main thing. This is the first line drug that is always used, ondansetron, or serotonin antagonist. You always use it as the first line treatment. Okay, other you have this dopamine antagonist, because dopamine normally leads to your, you can say, gut mortality, like a normal peristalsis. Okay, but if you give dopamine antagonist, it can stop that motility and can reduce your emesis, because in your, when you are vomiting, you are having increased peristalsis, antiperistalsis, right? So you actually decrease your dopamine levels, and that's why you give like dopamine antagonist, like a prochlorperazine, metoclopramide, things like this, and they all decrease your gut motility and suppress your emesis. Okay, it's very very clear. And I will tell you. For this, you can remember for all dopa antagonists, what kind of symptoms you can see is, you can see increased prolactin levels, because not normally dopamine inhibits your prolactin, right? And this dopamine again is like you can say released by the CTZ and leads to same thing. This whole emesis stuff is initiated from this zone, CTZ zone. So all drugs go and act here. Okay, and it can lead to those you can say neuroleptic malignant syndrome and stuff like this, like extrapyramidal symptoms, akathisia, acute dystonia, stuff like this, all this thing, because it's a dopamine antagonist. Okay, this you have to keep in mind. And I would tell you that yeah, this is it for most of the, I have told you most of the thing. Okay. And now I will tell you there is another one, and another, you can say, antiemetic drug that is also important, that is known as neurokinin or NK1 antagonist. Okay. This also works on your CTC zone, and this is only used for your chemo-induced nausea. For your serotonin, first line, whenever someone comes, you can say whenever someone comes with vomiting. Okay. The first thing you give is serotonin antagonist. Okay, but if they are vomiting, you can say their vomiting is not controlled, they are vomiting severely, then you can actually use this one, because chemotherapy actually leads to a lot of vomit that is uncontrollable even with high doses of drugs sometimes. So that's why this is more potent than this one, and it can be used. What questions do you actually get on your examination is the are more related to this serotonin rather than dopamine, NK, and stuff like this. Okay, there are other, you can say, histamine and muscarinic. I'll tell you one thing. On your CTZ you can have serotonin. Okay, that leads to your vomit. You can have dopa that can lead to your vomit. You can have your you can say, and like a cholinergic stimulation that can also lead to your vomiting, and your that thing, histamine, if they are released, these neurotransmitters, if they are released in this zone, they can induce vomiting. Okay, for this we have just studied ondansetron. For this we just studied metoclopramide and stuff like this. For acetylcholine, and we talked about this too also, that this is used generally as a first line for anything, for any vomit, for any misses, this is first line, and also used for chemotherapy. Okay, and for this is used mostly for generally nausea vomiting stuff, like generally if this doesn't work, neurokinin doesn't work, if or if patient is just vomiting, he was not on chemotherapy or something, you can give them dopa 2. Okay, for acetylcholine, you can actually, like acetylcholine, if it is increased in the CTZ zone, it can induce vomiting. Okay, so you need to give a acetylcholine inhibitor, which is scopolamine. Okay, scopolamine. And where it is used for motion sickness. Okay, it is used for motion sickness. It is not used for, like, as this scopolamine is never used for chemotherapy induced nausea vomiting, or generally when someone has food poisoning, you do not use these drugs. You use either serotonin or dopa, but dopa has a lot of extra pyramidal effect, so your first line is always serotonin antagonist. Okay. And so this scopolamine can act, is like an antiemetic, but it is only used for one purpose, which is your motion sickness, not for any other causes of your vomiting. That's the whole point here. Okay. Same goes for histamine. Histamine can be used for that thing, hyperemesis gravidum. Okay, hyperemesis gravidum. But clinically, at least I have seen, even in hyperemesis gravidum they use this, like in real world I have seen this, but in our book they have written this, so stick to the book. Okay. uh, you can use your antihistamines to suppress your vomiting only in one condition, when someone is suffering from hyperemesis gravidum. Hyperemesis gravidum is like when a female becomes pregnant, in the initial months she is very nauseous and she can vomit a lot. Okay. And if it's very severe, you name this disease as hyperemesis gravidum. Okay, because the patient keeps on vomiting, and the patient is like a kind of dehydrated and stuff like this. So you can use your antihistamines for hyperemesis gravidum. So H, for this you have to remember. I also remembered it. It ends with amine, so acetylcholine and amine maybe can help you remember. So yeah, these are your antiemetics. Okay. And now we will talk about our last topic, that is your constipation drugs. Okay. For your constipation drugs, I want you to divide them in few groups. Okay. First is your osmotic laxatives. Okay. And as the name suggests, it's a osmotic laxative. By osmotic laxative, it literally means like in your colon, you have a osmotically active compound. Osmotically active compound that leads to draw water inside this formed stool. Okay. And in this stool, you have this active substance that is sitting there, like a osmotically active substance. When we say osmotically active substance, it literally means like it likes to pull in more and more water. Okay. And so yeah, it will pull more and more water, it will soften your stool and can help with your constipation, simple as that. Okay. And example for this will be your polyethylene glycol. You can remember that this, you can remember lactulose. Okay. For lactulose, I would tell you that lactulose is first line, or you can say treatment of choice, especially in hepatic encephalopathy. This you have to remember this. This is very high yield for step 1, 2, and 3. They like to ask this thing, that lactulose can be actually used for your hepatic encephalopathy. Not like it is also used for constipation, but it can also be used for hepatic encephalopathy. Okay. What it does is, for lactulose, because it's a lactose component, right? So it pulls in water and helps constipation. Another reason why you use lactulose is because it can help with hepatic encephalopathy, but with a different mechanism of action, right? What it does is that your gut bacteria, they will utilize this lactulose and will make your lactic acid, and this lactic acid will trap your ammonia, and if your ammonia is trapped, you can have decreased excitotoxicity of your CNS. So that's why it helps with hepatic encephalopathy. Okay. So your lactulose, two functions, two uses: constipation and your hepatic encephalopathy. This is tested a lot. This is tested a lot. They want you to know mechanism of action of your lactulose. How does it help with hepatic encephalopathy? Okay. So it traps your ammonia ion in your gut. Okay. This is all about your osmotic laxatives. Okay. And then we have other ones that are bulk, you can say bulk laxatives or bulk forming laxatives. Okay. These are like your fiber thing that is sitting inside your gut lumen and pulls in more and more water. So like that's why we name it as bulk forming, because these are just fibers that are non-digestible and they pull in more water. Okay. So you can remember, there is a thing like methyl cellulose. Okay. And there's another one, I can't remember the name, but anyways, this is, at least you should keep in mind. Okay. Methyl cellulose, this is a bulk forming laxative. Okay. Another way you can help with constipation is your stimulant. Okay. Your stimulant laxatives. Stimulant laxatives are very simple. Okay. They actually stimulate your gut wall, simple as that, because they stimulate your nerves that are sitting inside your gut wall, like your mesenteric and your Meissner's plexus. Okay. They lead to the neuronal activation of those plexus, and it induces your gut contractility, so they help with constipation. Okay. What comes, like what names must you remember for this is your cinna, and your bisacodyl. Okay, cysteine bisacodyl. And then you have a stool softener. Okay, they actually soften the stool, decrease the surface tension, blah blah blah. This is just a word. You can say theory part, but you can just remember it's a stool softener. The name for this drug is Docusate. You can just remember this. All these constipation drugs, what are their adverse effects? They all lead to diarrhea or bloating. Simple as that. Simple as that. Diarrhea or bloating. Okay. And what else I should tell you? Uh, yeah, the diarrhea and bloating. I have told you this all, and then we have chloride activators. Okay, chloride activators. So for this, I want you to consider that this is your gut lumen. Okay, this is your lumen of your gut, and here's your stool. And what you do is you try to increase the chloride levels in this luminal area. When your chloride levels in this luminal area increases, okay, it leads and pulls more and more water. Okay, it leads and pulls more and more water. These are your chloride activators. Okay, and for this you can remember lubiprostone is the example. Lubiprostone, so starts with L, like chloride, lubiprostone maybe helps you. Okay, this is another thing that you should keep in mind. And also know, uh, I also remember that this same chloride activity can be increased by another drug, that is your that are your G stimulatory. Like they increase your CGMP thing. Okay, these are your intracellular molecules actually. Simple as that. That lead to more and more fluid and chloride secretion. Okay, it can be mostly it's chloride. Okay, mostly it's chloride. So they are very different from this lubiprostone. How lubiprostone directly activates the chloride channel. These things, like these drugs which activate your CGMP, these are your linaclotide. Okay, what they do is they do not activate the chloride channel itself. What they do is they increase the intracellular levels of this CGMP, and this promotes more and more chloride secretion along with the fluid secretion. This is an important point to keep in mind. Okay, so they all lead to again help you with the constipation. Adverse effects same, diarrhea and bloating. Okay, and last but not the least is your serotonin. As I've told you, like serotonin can actually increase your gut motility. Normally serotonin increases your gut motility. So if it increases your gut motility, you can give your agonist, serotonin agonist. Okay, you can give your serotonin agonist. Okay, and they can again increase peristalsis secretions and help you with the constipation. So that's all about GI drugs. And yeah, that's all about this GI drugs. If you have questions, like you can just ask me, I can tell you. Hello. Okay, we can actually cover hepatitis quickly. Okay, for hepatitis, for pharmacology I would tell you, uh, like it's a memorization. I understand nothing can help you but just memorization. What are the common, at least like common GI drugs that you must keep in mind? It's your PPI, histamine, the loperamide, the chloride activator, osmotic laxative, lactulose, and stool softeners. These are the main drugs that will like always be there on exam. Like at least something here and there can show up, but these are like very obvious on the examination. Okay, so you can
I have a
remember this.
question.
Yeah, yeah,
Yeah, cyclic GMP.
yeah,
What is
yeah.
the name of the medication?
For cyclical GMP,
Yes, chloride activators.
yeah, lubiprostone. And
Oh,
for CGMP related chloride, this is your linaclotide, like linaclotide.
imaclotide.
Okay, like they end with, yeah, this clotide word. They end with this clotide word. Okay,
Oh,
and okay, so
thank you.
this is your hepatitis. Okay, for your hepatitis, I want you to think of You can think B and C as one group because they both are kind of very similar. A and E you can keep together because they are kind of similar. And D is like it's a virus that cannot survive on its own. It's a dependent virus. So that's why it's hepatitis D virus. Okay. So first we will talk about this hepatitis A and E virus. Okay, both are your RNA viruses. Like for hepatitis, all are RNA viruses except for B. This you have to keep in mind. This is extremely high risk that your hepatitis B is a DNA virus, not a RNA virus. Okay, this is an exception. And if we talk about hepatitis A and E, what you need to keep in mind, both are fecal. Okay, both are fecal. For some reason, I have seen that for hepatitis A, they want you to remember that a daycare can be a source, shellfish can be a source, and even like traveling can be a source, like travelers, you can say, induced hepatitis. These three causes are always there on your exam when they want you to test on hepatitis A. And I have seen that they test mostly on hepatitis B and hepatitis A, like like majority of times. But of course, others can also show up. So this is one thing that is common with hepatitis A and E. And how can they present? A actually is it starts with A. You can remember it's asymptomatic. Okay, or if it becomes symptomatic, it is very, you can say it's self-limited. It resolves on its own. So there is like no risk that your this hepatitis will go and convert into cirrhosis or carcinoma. Nothing like this. But for E, it can be problematic. It leads to your, you can say, fulminant hepatitis, which means that it can lead to acute deterioration of your hepatitis, especially in pregnant females. This is the main thing that you have to remember for hepatitis E. Okay, and that's why this carries a risk of, you can say, it carries a poor prognosis because it leads to sudden acute decompensated hepatitis in a pregnant female, like a fulminant hepatitis, right? So it can actually lead to death of pregnant patients as well. So this is problematic, hepatitis E. But A is self-limited, does not lead to anything. So prognosis is good with this. As I told you, no risk for this carcinomas or stuff like this. Okay, and yeah, this is all about your hepatitis A and E. For hepatitis B and C, first difference, this is DNA and C is RNA virus. Okay, both are driven by your bodily fluids. Okay, so blood and you can say like a birth thing. They all can lead to hepatitis B. For hepatitis C, again, blood is there. But for hepatitis C, I have seen that if they ask about, like, if they mention IV drug abuser, and if they give you both options for some reason and you're confused what it is, go with hepatitis C. For some reason, IV drug abusers tend to get more hepatitis C than B. Okay. And I've just told you, like hepatitis B, 95% of the time, like 95% of the hepatitis B cases resolve. They do not go into chronic hepatitis or hepatocellular carcinoma or cirrhosis. But for hepatitis C, they can actually like 85% of your hepatitis C virus infections resolve. But compared to hepatitis B, you see like there is a difference. 15% people are still at risk of developing cirrhosis because of hepatitis C. So hepatitis C can actually, in majority, can lead to your cirrhosis and can lead to your liver cancer. Okay, this you have to remember. And what else I should tell you? Yeah, this is the main thing. There, I remember in your first aid, there is a histology thing. Do you really need to keep that in mind? Not as such, but I would just recommend just remember the buzzwords. Maybe I haven't seen in questions that they talk a lot about histology of hepatitis. Not as such. They always give you other hints to understand it very well. Okay, they always give you some hints so that you understand it very well. Okay, for hepatitis A, how can you prevent it? You can actually give hepatitis A vaccine. This is also important. You should remember this. For hepatitis B, you also have a vaccination. Like at birth, you give vitamin K and hepatitis B vaccine. At birth, this is the first thing that you do. Vitamin K, and then after, like within 24 hours, you give hepatitis B vaccine too. Okay, this you have to keep in mind. So for from all hepatitis, only B and A has vaccination. No other, you can say, other hepatitis. Okay. Hepatitis D, as I've told you, it's dependent. Especially it depends upon hepatitis B for survival. So if someone is infected with both hepatitis B and D, it can lead to severe deterioration. Okay. And last but not the least, that you should be able to interpret the labs of your hepatitis B. Okay, this is very important. They have always some questions on this. So I want you to understand these terms. Like they can sound very similar, but they're not similar. Okay, so you have hepatitis B surface antigen. In if you see this word, what where you have to focus on this AG, like antigen. Okay, and then you have another word in which they use anti HBS, like it's an antibody to surface hepatitis B. Here you have to focus on this word anti. Okay, and then same goes for your core antibodies, like anti hepatitis B core antibody, and then you have hepatitis E antigen, and then again you have hepatitis E antibody. Okay, all these things. If I'll tell you the interpretation of this. There's a one rule: if you have acute hepatitis, your IgM would be raised. This is a rule that is true for all disorders when it comes to IgM mediated immunity. Okay, acute conditions IgM is elevated always. Then you have class switching, because your all of your B cells and T cells, they're activated and they lead to the more class switching. The reason why we see, like, all whenever you have something foreign and your plasma cells are there to make immunoglobulin, the first immunoglobulin that is produced and that gives you immunity is always IgG. So acute condition, what kind of immunoglobulin would be increased? IgM always. If you see that on your laboratory workup, IgM is normal or decreased, whatever, but your IgG is raised, it means it's a chronic infection. This is very high yield point to keep in mind. Okay, so I hope this is clear, and this is like just a rule that I just told you. So now if I say antibodies, they can be IgM or IgG depending upon acute or chronic situations. This I have to just interpret in my questions. Okay, and if I had to say about the surface antigen, and this literally means if your only surface antigen is positive, it means you are just infected. You do not have immunity, you are not even vaccinated, nothing like this. You are just infected because you got this antigen. Correct? If I say that your only anti-hepatitis B surface, like antibody against this hepatitis B surface is elevated, only antibody, like surface antibody is elevated, what comes in your mind? It means you are vaccinated. Okay. So ask yourself, if I see hepatitis B surface antibody, only this is elevated, vaccination. If I see only hepatitis B surface antigen, infection. Infection with no resolution, no immunity, nothing like this, just a pure acute infection. Okay, and yeah, this is the thing. And then I'll tell you, when you see hepatitis E antigen, it means infectivity. Okay, it means infectivity. You have to remember this. Okay, it means how much infectious your blood is, so that it can lead to like it can replicate very well. Okay, so if your E antigen is elevated, it means infectivity, or you can just write it as infectivity. Okay, and if I have, you can say, developed this antibody, it means my infectivity is low. Okay, it means my infectivity is low. Okay, I hope you guys are very clear. And of course, if someone is showing this hepatitis E antigen and antibody to hepatitis E, of course their HB SAG is going to be positive, because firstly they have to be positive with the antigen, and then then your hepatitis B will replicate, and then you can see it through the antigen thing. You see infectivity, it means it's replicating inside the body, it's leading to more and more infection, and it can actually be transmitted to other person, and the other person can have it, like, very severely. If you see antibody thing that is high in your serum levels, it means you are immune to that thing, you are at low risk of infectivity. Simple as that. Okay, and mostly this infectivity part is done for your chronic hepatitis, to look at your chronic hepatitis, not with acute. Because in acute, you are of course going to have hepatitis E antigen positive. This is all logically true if you think of it in this way. Okay. So I hope this whole thing is clear. And now we have two more things. Actually, yeah,
Can you
actually
please
two.
explain it again?
Yeah, yeah, sure. So I'm saying there are like two conditions. If I say someone is hepatitis B positive, this logically means their hepatitis B surface antigen should be positive, correct? It means they're positive with this thing. And when we talk about hepatitis infections, it means I will like my serum will have whole infection, right? I will have those capsular proteins, surface antigens, the core antibody or core antigen, or even the infectivity represents like how infectious this pathogen is, so that it can infect your own cells or to someone else. Okay, so this is your infectivity. This is represented by hepatitis E antigen. Okay, if I like there is no condition in which you can see only hepatitis E antigen being elevated. Like there is no condition like this. Like isolated hepatitis E antigen elevation is not possible. Okay, because you must be hepatitis A antigen positive. So like there is this whole combination that you have to interpret. Okay, okay. So if I say someone is hepatitis B positive and their surface antigen is positive, okay, and then I say that their hepatitis E antigen is also positive, this means that they are having high infectivity and they are having chronic infection. Okay, correct, right? And if I say that this is negative, it means that the patient is low infectious. So I want you to focus on this thing. Whenever you see E thing on your labs, think of infectivity. If antigen is increased, more infective. If E antibody is increased, it means less infective. They will always make it positive. Like hepatitis B antigen will always be positive. Okay, okay. And now, if we talk about if someone has, you can say, recovered from hepatitis B infection, it means your hepatitis B surface antigen would be negative because they have recovered. Right? Think of this logically. You don't need to memorize. If you think of this all thing logically, it will make sense to you. And this means my anti hepatitis B surface would be positive because I'm recovering from this thing, right? So my antibody, like the surface antibody, would be positive, of course, correct? And there is a thing I just mentioned, like a core antibody. Core is positive for all of the things. Core is positive for all of the things. The anti core hepatitis core is positive for all of the things, like in all situations. You can say in recovery phase, in window phase, chronic infection, acute infection, like in all this stuff, your core is positive because you have the core of your hepatitis. Like the core is like the nuclear part, like a nuclear antigen is always going to stay there inside your body. So that's why your core is always positive. How do you know that you actually had acute infection? If you see IgM elevated for this, it means you just acutely got infected. If you see IgG elevated, it means it's a chronic infection. Okay. So hepatitis score is positive for all situations except for two. That is your immunization, because in immunization you are not actually exposed to the actual hepatitis itself. You were just immunized. Okay. This is one situation I was telling you about the recovery. Okay, so for recovery, it means your hepatitis surface antigen would be negative because you're recovering from this disorder, but your anti hepatitis B surface antibody would be positive. I hope it makes sense. It's very easy. And core, as I said, once you are infected, what kind of antibody stays inside your body is your core. It tells you that this person was previously infected and now has recovered, no more symptoms or stuff like this. But now your core, if someone is positive with core antibody, it means they were infected at one point in their life. Okay. So this is it. And again, if we talk about the hepatitis E antigen, again it will be negative, and your hepatitis E antibody would be positive because you are in the recovery phase. Correct? Like I hope this all makes sense. It can be overwhelming. You do not need to memorize this. You can just think of this logically when a question comes up. Okay? Think of it this
Doctor,
logically. Yeah, yeah.
Can you please repeat about the core antibody thing?
Yeah, core antibody thing. Okay, so I'm telling you, like, this is your hepatitis molecule, you can say a viral particle. Okay, this has this DNA sitting inside. So what are antigens? Antigens are, you can say, foreign particles that are detected in your body, including this hepatitis DNA. So this antigen is a part of your core. Okay, and if this core is positive, it means you are infected, right? And if you develop antibody against this core, okay, it means you are, you can say, recovering, or you are in window phase, you are in acute phase, but this is going to stick inside your blood always. If you check antibody core levels, they are going to be positive, because it means you were firstly or previously at one point infected, because core is something that you cannot eradicate from your body. Okay, you can just develop antibodies to that thing, but you cannot completely eradicate. Okay, so your antibody C or core hepatitis is going to be positive. This antibody is going to be positive in all phases. Okay, I hope it's clear. And there's a one last, you can say, situation that is known as window phase. In window phase, what happens is that you are transitioning from your acute infection to your resolution. Okay, and what does this literally mean? Like acute infection, hepatitis B surface antigen has to go down, and resolution means that your hepatitis anti-hepatitis B surface has to go up. This is your resolution, of course, right? And you have to, like, they cancel out each other, so that's why no antibody is positive except for this core thing, because as I just told you, core is going to stick there, it's going to stay there. Okay, that's all about hepatitis B
So
lab
it's a
interpretation.
IgM type of
Yeah, yeah.
the anti-HBC is the IgM type or IgA.
In window phase,
Yeah, yeah, exactly.
yeah, IgM, because window phase is after the acute phase. And we count acute hepatitis for this hepatitis B until 3 months. Like you can still name it as acute hepatitis. After 3 months, it becomes chronic, and then you have the class switching, like IgM converted into IgG. So window phase is like very close to your acute infection phase. Like your body immediately responds to your acute infection, and that's why in window phase your IgM core antibodies elevate. Okay.
Yeah. Thank you so much.
Okay. Yeah, so I would say, think of these things logically. Literally in question, they'll give you the hints that is a acute infection or chronic. So first thing that you see these words, think of IgM, acute, IgG, chronic. Then just interpret the thing, what are they giving you. If they're just asking you about immunized person, what do you think should be positive? Only one thing should be positive, that is your hepatitis B surface antibody, because they did not got infected in the first place, they are just immunized. Correct. Things like this, acute infection, what will you see? Hepatitis B surface antigen being positive, and your hepatitis B core antibody being positive. Again, what kind of IgM? Hepatitis E antigen positive, but no antibody formation, because it's acute infection. Correct. Things like this. So I hope it's very clear, and no one has any questions. If you have, you can just ask me.
So, a vaccinated person will his
Yeah.
HBC will be negative. Antibody HBC.
Sorry, can you repeat your question again? Your voice was not clear.
I said if a person gets vaccinated from hepatitis B vaccine, his core
Mhm.
antibodies will be negative.
Yes, yes, correct.
Okay,
Very
okay,
good,
okay,
correct.
okay. Thank you.
Okay, so, okay, then we're done for the day.
So I have one question.
Yes,
So doctor, if someone
yeah,
is
go on.
if someone is career if someone is infection,
Hmm.
so in that case there would be only some antigen would be positive, or or what about other, like stuff like core antigen, or other hepatitis E?
Your voice is
What is
very
that?
distorted.
What is
I
that?
just understood hepatitis E and core. Can you just repeat it again?
Like in case of career, so what picture we can get in case of career?
Oh, so you're saying if someone is carrier, what will you see? You will see
Yeah.
anti-hepatitis B core being positive, and if they're carrier, it really depends if they are in acute phase or in chronic phase. So hepatitis B core is always going to be positive. Hepatitis E, if it is acute, is going to be negative, like antibody thing, but antigen is going to be positive. Okay. Hepatitis B surface antigen, again, if it's acute, it's going to be positive. If it's chronic, again, it's going to be positive. Like in these two phases, because you are chronically carrier of this disease, right? But antibody against this surface is going to be negative. Okay.
Okay. Thank you.
Thank you. Yeah. Okay, so I'll see you guys tomorrow.
Thank you so much.
Yeah, no worries. Bye.
Thank you, doc. Thank you.
Yeah. Yeah, no worries.
Thank you, Dr.
Thank
Lise.
you, Dr. Lise.
Thank you.
Bye.
Thank you.